presentation on bradycardia with a pulse. It's very important to do a complete assessment to rule things up. Patient presentation is a big positive that you have to do. As soon as you go in, look at the patient, check their mental status, make sure you get all your vital signs, which include the blood pressure, the heart rate, a 12-lead EKG, respiratory effort, which would include a pulse ox and end-tidal CO2 if you can. Check their blood sugar, their temperature, and try to get a complete medical history on the patient. Symptomatic bradycardia includes altered mental status, hypotension, ischemic chest pain, syncope, shock due to bradycardia less than 50, seizures, respiratory distress, and all of the above require treatment right away. Reversible causes. Hypovolemia can reverse with fluids, hypoxia with oxygen. Your hydrogen ions or acidosis, again, oxygen, and with medical orders, maybe some bicarb. Hypothermia, hypokalemia, and hyperkalemia. Your tension pneumothorax, your cardiac tamponades, your toxins, possible PE, which you won't know in the field. You possibly can suspect it, and your MI. Current medications in the protocol: oxygen, fluids, of course. Atropine is still in the protocol for bradycardia with a pulse, epinephrine, and pacing. You can also consider some glucagon if the patient's on beta blockers. Consider calcium for calcium channel blockers, and dig toxicity will eventually cause a severe bradycardia. Indications: atropine is given for hemodynamically compromised bradycardia, symptomatic sinus arrest or block, and your AV blocks at the junctional level. The atropine is not going to work in patients that's had a heart transplant because the vagus nerve has been severed. And use real caution in patients that are having STEMI criteria, because bradycardia may be used as a protective measure. Epi, they're using Epi now. It's used in severe bradycardia that does not respond to atropine or cannot respond to atropine due to heart transplant where the vagus nerve has been severed. And you can administer Epi 1 to 100,000 while setting up your pacer in severe cases. That'll buy you some time to set your pacer up. You may choose to use pacing in older patients or administer very cautiously in older patients that have angina or coronary artery disease. It may cause severe hypertension in those taking beta blockers, so make sure you get a good medical history and know what medications they're taking. And there's no true contraindications, because if you don't do this, the outcome will be very negative and possibly death. Medication dosages: atropine 0.5 every 3 to 5 minutes. IV push or IO, not to exceed 3 milligrams. And you need to be careful and push that quickly, because if you push it too slowly, it can cause reverse effects and cause more bradycardia. Fluids: start with a 250 bolus, a total of 2 liters. Reassess your lung sounds after each bolus, and be extremely cautious in any patient that has a history of CHF. Oxygen 4 to 6 liters by nasal, or 10 to 15 by non-rebreather. You want to be at least 94% and try to keep your end tidal between 35 and 45. Epinephrine, you can give 20 to 40 micrograms IV push or IO every 2 to 3 minutes till systolic is greater than 90. You can give If you give cardiac epi, if it's available, you give 0.4 milligrams of 1 to 10,000. Your epi drip is 2 to 10 micrograms a minute till systolic is greater than 90. So 90 seems to be the magic number that you're shooting for. And you can mix 1.1 milligrams of 1 to 1,000 epi and 10 cc's of saline to get 1 to 100,000. If no improvement, transcutaneous pacing. Do not delay pacing with a high AV block, which could be second or third degree. If you think the patient is going to benefit from pacing, do not delay it. Signs of improvement. Improved mental status, improved blood pressure, strong radial pulses. And all of these are a result of your initial assessment. That's why it's important to have that initial assessment. If pacing capture is confirmed with a radial pulse and pacer spike. And pacer spikes in front of every QRS. So make sure you get your first 12 lead, and you can confirm it with your other 12 leads, and make sure you have a radial pulse with every pacer spike. Stable symptomatic bradycardia. These patients really don't need you to be super aggressive. The bradycardia may be a protective mechanism, so be cautious with that. Unstable symptomatic bradycardia. These patients will not have a positive outcome unless you act quickly and aggressively. Atropine works on the vagus nerve, so the medication would be ineffective in heart transplants. It's very effective in vaguely medicated bradycardia. Atropine may be ineffective in heart blocks, and it's only effective in 28% of the patients. So you really need to do an assessment after you administer the atropine. Atropine will not work on patients on beta blockers, low pressor, propranolol, atenolol. So again, your medical history and knowing what medications are on is important. Epi and Bradycardia now. Epi may be more beneficial in bradycardia as it stimulates the entire myocardium. It stimulates the atria, the SA node, the ventricles. Thus, epi is effective in a broader range of patients. It provides changes in heart rate. It can increase the heart rate. It increases the force of contractions. It constricts the large arteries and will not cause paradoxical bradycardia. Again, do not delay pacing if the patient is extremely unstable. Know your equipment. Know the monitor you're using. Some of the monitors have demand pacing, and some of the monitors have fixed pacing. Excuse me. Make sure you're on the fixed pacing. Make sure you have good pad placement. Poor pad placement could cause failure. Insufficient milliamps. You want to make sure you increase it as needed to keep capture. Make sure your pads are on securely so you have good impedance. Movement of the patient can change the placement of the pads, so make sure if you move the patient, you reassess your pad placement, and make sure you have the proper rate set. If you're not getting capture, increase your rate along with your milliamp. Very important to do a thorough assessment and rule out other causes that can be reversed before you get extremely aggressive, such as applying some oxygen on the patient, give them some fluids, simple things like that before you go real aggressive, unless the patient is extremely unstable. Symptomatic versus asymptomatic. If symptomatic, they're stable or compensating or unstable. Have your treatment plan in place and do not delay pacing if patient is extremely unstable. Just a couple rhythm strips. This one is digitoxicity. and it's a classic one that shows atrial tachycardia. The P waves are coming through about 150 beats a minute, and it's at a high grade second degree AV block. So it's about a 4-to-1 ratio with PVCs also, and this is a classic one for dig toxicity. Beta blocker overdose. This is a sinus Brady with a first degree heart block with a heart rate about 45. You can see it's starting to get some peak T waves. The PR interval's long, and this is an early stage of a beta blocker, calcium channel blocker overdose. And this one is a propranolol overdose. It's a calcium channel blocker overdose. QRS is widening greater than 100 milliseconds, and it's got a positive R wave in AVR. Normally the heart rate would be slower than this in calcium channel blocker overdose, but this is a propranolol overdose, and basically this is what you might see in a calcium channel blocker overdose.